Good morning, bonjour, and it's a great pleasure to be here. Sorry, my French is very poor, and I'm honored to be here, and thanks to Professor Mario Dil for inviting me. And it's also a great honor just to give this talk after Professor Malla, who's been one of my mentor, and thanks for your introductory lecture. And today I've been asked to focus a bit more on how to optimize preventive psychiatry, and specifically how to improve detection and prediction. Those are my disclosures, and these are the take-home messages I would like to discuss with you today. Rational background for preventive psychiatry, how to improve detection of young people at risk, how to improve the prediction of outcomes, and quickly how to improve the way we can prevent outcomes, so which interventions we can offer. So I usually start from the real-world patient's perspective. So why are we here today? Why we're discussing early intervention and prevention? We know that psychosis is a burdensome condition, but if we ask patients, and that's what we've done in this co-productive joint venture with Experts by Experience, which was published in World Psychiatry, the top psychiatric journal, this article was co-written with patients themselves. And what they teach us is that psychosis ultimately is one of the most painful and upsetting existential experience, so apparently alien to our typical patterns of life, but at the same time so unspeakably enigmatic and human. So we are here today try to improve and ameliorate this condition. I think that's very important always to start from this perspective. So that's the first rationale. What about science? What is science telling us? This is one of the of my most widely cited papers from my lab. It's nothing surprising. So we wonder, okay, let's have a look at the peak age at onset of mental disorders globally. And we reviewed about 200 epidemiological cohort studies. And the answer is, I don't have the pointer, but basically the peak age at onset across all mental disorders, not just psychosis, it's 14 years. 1/3 before age 14, half before age 18, and vast majority, 63%, before age 25. So this means that when you assess someone, an adult with mental disorders, it's very likely their problems that have started in adolescence or in their childhood. So it's very likely there is a problem with a delayed detection, prevention, and intervention. That's what we have heard from Professor Malla. The other background rationale is basically offered to us from the so-called clinical staging model. You are all familiar with that. Only quickly going through that. In most cases, for example, of psychotic disorders, not all of them, I would say the vast majority, 70% of them, psychosis develops across clinical stages. On the horizontal axis, you have the neurodevelopmental phases. On the vertical axis, you have the level of functioning or symptoms, vice versa. The dotted line is the threshold at which we diagnose a mental disorder, and the top line represents the normal trajectory of a healthy person. As you can see, usually psychosis develops with accumulation of risk factors at around the perinatal period, and then individuals progresses and they may accumulate disability, functional impairment until the so-called clinical high-risk state for psychosis, which is associated with a very high risk of developing psychosis, and then they may enter into the relapsing stages and into the chronic stages. And this is not just true for psychosis, but also for other mental disorders, for example, for bipolar. But let's keep, again, the patient perspective and be very pragmatic. So this is John, a 15-year-old boy born to a couple of immigrants living in London. And we all know that immigration is an independent risk factor for developing psychosis, as demonstrated at meta-analysis globally. But also living in London, urbanicity, like living in Paris, is another independent risk factor for developing psychosis. After 6 months, John becomes socially isolated and withdraws from schools, friends, peers, his typical hobbies, and starts smoking cannabis. Social isolation and cannabis are two additional risk factors for developing psychosis. Again, there is meta-analytical, strong epidemiological evidence supporting them, controlling for several biases. And you see that some of these factors that are potentially can be targeted by preventive approaches, and that's why we start thinking that possibly we should detect these factors early and intervene earlier as well. But unfortunately, after 1 year, John becomes really unwell and starts developing the so-called attenuated psychotic symptoms or unusual experiences. Those are, let's say, fleeting psychotic-like features that do not meet the diagnostic threshold for receiving a major diagnosis of psychosis because they are either not frequent enough or not severe enough. Like, for example, John is having the impression that someone is looking at him on the street, but this impression only lasts a few minutes and he's still able to criticize it. So it's not a delusional feeling. And these are Instagram drawings made by my patients trying to make sense and illustrate their unusual experiences. You see hearing voices when nobody's around you, or thinking, having strange thoughts, having the impression that the world is somehow fabricated. But importantly still, these experiences do not reach the delusional intensity. The scope of prevention, indicated prevention, is just to bring John to kind of a normal trajectory, to give back his life. How can we do that? That's where basically I try to implement preventive psychiatry. That's kind of the clinic where I work. I forgot to say it's called OASIS, like the rock band, outreach and support in South London. That's the OASIS clinic in a typical sunny day in London in August. And but you'll see that there is no NHS sign, there is no mental health trust. It's an ugly standard London building, and it could be a post office, a private apartment, because we are kind of working outside the main psychiatry, and we wanted to facilitate access to care, as Professor Malla said, in a non-stigmatizing, inclusive approach. And also, what we are trying to do here is to adopt a prospective way of taking care of John and similar young persons. This is very different compared to our usual standard of practice, because we typically are within a kind of so-called reactive system where we sit and we wait for someone to be unwell and then we provide care. This is not really efficient. It can be associated with a long duration of untreated disorders, as Professor Malla taught us. So we need to enter into a so-called proactive way of taking care of these patients, which means going in the community and trying to detect and identify young people like John with subtle problems. And another core principle of preventive psychiatry, again already discussed with Professor Malla, is to offer transitional care. In the UK, I think also in France and in Europe, there is a huge split between children and adolescent mental health services and adult mental health services, and this two-tier system is typically split at around age 18. And basically people, they fall in the cracks of this two-tier system when they need help the most. If you look at the epidemiological evidence, the meta-analysis I showed you, at the clinical staging model, there is no discontinuation at around age 18. This is an artificial barrier which we have created because of issues other than science, and we need to really to overcome them. So OASIS is offering care people age 14 to 35. How do we detect then people at risk for psychosis? For example, in South London, we have this leaflet. It's been produced with expert by experiences. Many young people going through difficult times do not know who to turn to or where to get support. OASIS is an NHS professional team, so it's public, it's funded by the state, and supporting people who are having problems with different types of stress, anxiety, depression, and experiences like feeling paranoid or hearing voices. There are two words missing, psychosis and schizophrenia, because it's prevention. We try to deal with risk, likelihood of developing psychosis, but it's not with most of these individuals that will not get a diagnosis at baseline. So we need to be very mindful of that. And I will address this later on. We also have a website where people can find useful information for family support, mental health literacy. They can make a self-referral. We have a walk-in clinic which is open, again trying to provide easy access to mental health support. This is all good, but may not be enough to detect many young people in the community. So we also try to champion digital health and to implement a bit more refined detection approaches for people at risk for psychosis like John. For example, we are running a Wellcome Trust funded program which is called Enter, e-detection tool for emerging mental disorders. It has been originally deployed in London, Glasgow, then in Italy, and now we secured an European grant to implement it in different European countries, Spain and in Nordic countries. And basically what this program is doing is we implemented a short questionnaire on a website together with a cognitive assessment, short cognitive assessment, and an automatic speech analysis, and the algorithm is automatically estimating whether individuals may be at risk for psychosis, and if so, they basically are recommended to approach the local preventive clinic. We have disseminated the project with a QR code through social media. That's the way today to approach and to talk with young people, and you can see that particularly Facebook and Instagram, they've been quite useful. We also targeted colleges, and it depends on the local settings, the outreach campaign, but this is again telling you that to prevent mental disorder, we need to be proactive. We need to contact young persons where they live and communicate with their own settings and languages. And as I said before, people were then invited to complete this automatic assessment, and the algorithm was estimating a likelihood of developing a certain disorders, psychosis or bipolar, and if the individual was above threshold, they were invited to contact the preventive clinic, OASIS, for a proper assessment. And this is a kind of way of risk enrichment, digital risk enrichment, way of screening thousands of individuals. We screened about 5,000 individuals and detected about 200 for being at risk for psychosis. And now we are scaling this up, as I said, in different European countries. Okay, we can also do something more and implement a bit more refined digital screening methods, for example, leveraging electronic health records, which are, for example, available where I work in South London or in the US, in some European countries. Now trusts they are paper-free, and all the notes they are recorded into electronic health records. And this is a precision psychiatry algorithm which has been co-produced with the industry, Lundbeck, and developed in the IBM database, representing about 50% of the US population, using all predictors, not just notes made by psychiatrists, but also notes made by general practitioners or any other healthcare professionals. And it was a dynamic risk algorithm estimating, predicting the likelihood of developing a first episode of psychosis. And the idea was then to, the idea has been then to test whether this was useful to screen electronic health records at scale to detect people like John who may benefit for additional preventive approaches. And we are doing a lot of research in this field, which I'm happy to discuss should you have further questions. One of the core benefits of these electronic health record approaches is that we've been also able to implement them in clinical practice. And this is quite challenging because I'm sure you have seen many publications presenting precision psychiatric models, but if I ask you how many of them do you really use in your clinical practice, it's very hard. I mean, only, let's say, 1% of the clinical prediction models currently developed and validated for psychiatry, they enter kind of clinical practice. We managed to pilot this kind of the use of these automatic screening methods based on precision psychiatry, artificial intelligence in South London, and for 6 months we implemented this algorithm in the local electronic health records and screened thousands of individuals. There are obviously ethical and safety data safety concerns, but which were fully addressed together with clinicians and the local governance and the patients. For example, in South London, there is a opting out options for patients if they don't want their data to be used for research, which gives us a bit of leeway for using the electronic health records for research, and data were anonymized and so forth. We have been able to screen 3,000 individuals in 6 months, and this was an implementation study of precision psychiatry, and the main outcome was clinicians' adherence to the use or to the recommendations made the calculator, because you can imagine even if you have the most accurate risk prediction tool, but it's not being used by patients or it's not being accepted by, it's not being used by clinicians or accepted by patients, then the risk calculator will be completely useless. And we found that about 70% of clinicians were adherent to the recommendations made the calculator, which were again, maybe consider making a referral to OASIS for a further assessment for mental health vulnerabilities. And with a bit of outreach, meeting these clinicians and telling them what the calculator was about, we were able to boost their adherence to 85%. So this is one of the few real-world implementation of precision psychiatry for early detection of mental disorders in young people. When it comes to prediction, so we talk about detection, we still have to address prediction and interventions, then what is the likelihood of developing severe mental disorders in people like John? And this is the last meta-analysis. On the horizontal axis, you have time from initial OASIS assessment. On the vertical axis, you have cumulative risk of developing psychosis. And if you follow the main Kaplan-Meier meta-analytical summary, which again represents what we know across about likelihood of developing psychosis across different studies in the globe, you will see that about 30% of individuals would go on to develop psychosis in 2-3 years' time. And the risk is still increasing in the longer term, but it's kind of the likelihood is a bit lower. So most transitions that will occur from a clinical high-risk state to a first episode psychosis that will occur within the first 2-3 years, which means that if you want to prevent the first episode of psychosis in people like John, you need to be prompt and intervene earlier and offer preventive package of care in the very first months since the initial assessment. Otherwise, it's too late. This is all good. 30% will develop psychosis, 70% will not develop psychosis. However, technically, this would be the so-called false positives, but there is some misconception with respect to false positives in this field, and false positives are only in relation to the primary outcome, so development of psychosis. Doesn't mean that 70% of people who would not develop psychosis will fully recover. In fact, we have demonstrated that we still have other mental health problems. One of the limitations, however, is that, as you can see, we can only achieve today in terms of prediction a group-level prediction. We assess people like John. We use psychometric instruments like the CARMs, the SIPs. You don't have time to go through them now, but we formulate a group-level prediction. You are at risk, you are not at risk. We are not really able to identify and to formulate subject-level personalized prediction of the likelihood of developing mental disorders. That's why we are running international global cohort studies like the AMP, Accelerating Medicine Partnership, which is funded by NIH in the US. It's a cohort study aiming to recruit about 2,000 individuals at risk for psychosis. Here we say the slide says only 1,000 because this is one of the arms of this big project, and there is a second arm which is also recruiting 1,000 individuals. It's a joint venture between NIH and the industry. It's about 100 million global effort involving 42 sites in America, Europe, Asia, and Australia. And we have basically scanned in the people, assessed people like John using multimodal assessment methods, psychopathological assessment, cognitive assessment, neuroimaging, brain imaging assessment, genetics, digital sensoring, and digital app, and also electrophysiology. And these have been acquired baseline, and the idea is, hopefully in the future, to be able to produce with artificial intelligence and digital tool to be shared with clinicians to predict the likelihood of developing psychosis in people like John at the individual subject level, so a personalized prediction of outcomes. and the results are not ready yet, but we are kind of completing the baseline recruitment and completing the follow-up. We have heard from Professor Mala that preventing psychosis per se, it's okay-ish, but it's not ideal. We should also open the door to other mental disorders. I agree, but that's why we would need validated instruments to assess people who are at risk of developing mental disorders other than psychosis, and that's why we developed a new instrument which is called CBAR, semi-structured interview for bipolar at-risk states, which can complement the psychosis risk semi-structured interview. It only takes half an hour, and we can now also detect individuals who may be at risk not for psychosis, but also for bipolar disorder. And obviously there is an overlap. You can be at risk for both conditions. And also we have developed a proper psychometric training package which can be delivered remotely. It's one-day training delivered by Maudsley Learning, and this is the contact homepage should you be interested. That's available, and we are training different cohorts in Europe. Okay, and in the final few minutes, let's just review what can we do to prevent psychosis once we have assessed people like John and ascertained that they are at risk of developing psychosis and then predicted their outcomes, 30% risk in 2 years. What are kind of the current clinical guidelines? We know that, for example, NICE are recommending using talking therapy, specifically cognitive behavioral therapy, with or without family intervention. It's not perfect, and we still need to improve it. We'll spend a few words in the next slides. What we know is that if we offer cognitive behavioral therapy to people like John, we can basically halve the risk of developing psychosis. We cannot eradicate that, but we can halve. But that's already a substantial achievement. And importantly, all guidelines, not just NICE, but also the European Psychiatric Association, they say do not offer antipsychotic medication. Why? Well, first, because, as I said, if you remember the meta-analysis, the Kaplan-Meier plot I shared with you, I told you 30% of people at risk for psychosis will develop the outcome in a naturalistic perspective. 70% will not. If we are going to expose 70% of individuals like John to unnecessary side effects like cardiometabolic side effects associated with antipsychotics, that would not be a good strategy. It would be a bit unethical and not really efficient. On top of that, there is no evidence that antipsychotics are really effective for preventing psychosis in people like John. And the third point, which is a personal point, I don't think it's conceptually good because I think that we should have different interventions according to the different stages of the disorders. For example, cardiologists, they do not use heart transplantations to treat high blood pressure. They have different treatments. So antipsychotics should be reserved to the first step of psychosis and the subsequent stages. Maybe people like John who are refractory to talking therapy, cognitive behavioral therapy, at some point they are about to develop psychosis, and only at that stage then we can consider antipsychotics. But to prevent psychosis, we should have different interventions. And when I say different interventions, talking therapy, it's good, but what about novel compounds? So I'm happy also to announce a new trial, which is an international trial funded by the Wellcome Trust. It's a 20 million grant, including 3 different arms, one of which is the trial PROMOTE, improving outcomes in individuals at clinical high risk for psychosis using cannabidiol, double-blind, randomized controlled trial, and I'm chairing the PROMOTE infrastructure across different sites in Europe and elsewhere. And the compound we are testing is cannabidiol, which is an ingredient of cannabis. Make sure you don't go home saying, oh, Professor Fusar-Poli actually recommends using cannabis to prevent psychosis. That's not correct, right? It's only cannabidiol, which has been selected compound, which has been shown to be anxiolytic, mood stabilizing, and antipsychotics. And our colleagues in neurology, for example, are already using it to treat other conditions like treatment refractory epilepsy. And this trial is about to start in a few months. In in the last few minutes, I also just want also to review the benefits we can achieve with preventing psychosis or bipolar, even if, for example, let's say we try cognitive behavioral therapy, we try cannabidiol, but still John develops psychosis. Is it still worth trying to prevent psychosis? Yes. Why? Because still we can reduce the duration of untreated psychosis. I have heard from Professor Mala how important it is, and how important it is to be timely. Try to intervene in the first 3 months. So typically one question I'm asked is it possible to cure schizophrenia? And my answer is, it depends how fast is the detection and how fast you can intervene. So time is crucial. And if you look at this meta-analysis, it's telling us that there is a strong association with DUP, duration of untreated psychosis, and outcomes. The longer the DUP, the poorest the outcomes in terms of negative symptoms, positive symptoms, global psychopathology, functioning, social functioning, and so forth. And on average, the DUP for psychosis is 2 years. If you have first episode services, maybe it's 1 year. But 1 year is, as we have seen from Professor Mala, it takes a long time for people to receive treatment. So at OASIS, if people develop psychosis, despite our preventive effort, the DUP is 2 weeks. So we are able to reduce the DUP from 2 years to 2 weeks, which makes huge difference in terms of longer term outcomes. That's not surprising, because we have been working with John prospectively and following him and monitoring his mental state over time. We have been working with his family, his insight is retained, he's trusting us. It's easier to start an antipsychotic, to admit to hospital if that's needed, so the DUP can really be reduced because of that. What has been the real-world impact of preventive approaches for psychosis? For example, at OASIS, we have appraised them in an audit, and I'm going to conclude in a few minutes. And we have demonstrated that over 20 years of preventive care implemented in the NHS, the OASIS has been the largest preventive mental health service in the UK, one of the largest in Europe, providing non-stigmatizing, inclusive engagement of young people, particularly the ethnic minorities, sexual minorities, with a demonstrated prevention of the first episode of psychosis and the confirmed cost effectiveness. You save about £1,000 per detected case. You need to invest a bit more in the first 2 years to set up the program and to train, for example, professionals on the CARMs or the CBARs, depending on what you want to prevent. But eventually you save. And you save on what? On hospitalization, on chronicity, on compulsory admissions. And these outcomes have all been supported by evidence, even by meta-analytical evidence, so the data are there, already published. And as I said before, we can achieve an improved outcomes even if psychosis develops. It's an internationally recognized clinical academic model which has attracted about 10,000 scientific citations, impacted several clinical guidelines, and attracted about 50 million grant income in the past 5 years. And because of that, the team has been awarded a couple of years ago prestigious national award for innovation in community mental health, and it has been selected about 700 applications from the whole UK. But to conclude, I just want you to listen. What I started with, the kind of the lived experience with the patient perspective. I just want to conclude still with their impressions. So I have a short video. I don't know whether it's you can hear that. Let's try. And again, we have asked OASIS patients, what do you think about being under the care of this team?
So both of you, through different routes, end up coming to OASIS. Can Olatunde, you say a little about what support you received from OASIS, in particular if there are things that were helpful?
To be honest, for anyone struggling, OASIS is literally heaven on earth. I remember when I went to the OASIS, they received me with open hands. Whenever I needed help, OASIS was always there. If it was a letter needed, OASIS was always there. Days when I felt so low, didn't want to do anything, OASIS were always there.
Okay, thank you. And obviously, the next steps are to support and expand and reach our preventive effort through collaboration. That's why I'm here. That's why it's been a pleasure to collaborate and work with Professor Krebs. And also through this European network funded by European College of Neuropsychopharmacology, which I have the pleasure to chair. It's a network for prevention of mental disorders and mental health promotion, and you are welcome to follow it or even to join it. Thank you very much.
Merci beaucoup pour ce très beau panorama des dispositifs tant de détection que d'intervention précoce. S'il y a des questions, on a un petit peu de temps pour quelques questions. En français ou en anglais.
Thank you so much, Paolo. I really think the presentation of the ENDER program is, well, requires attention. I was wondering how they access, what kind of access the patients have. Do they just click on anybody can click on the program? And how do you manage the referral after that? Is that only to go to OASIS services, or do you have more, well, wide referral?
So the patient, thank you, very good question. The patient, they are presented on social media, enter, and there is a QR code, for example, and they log in. There is a consent form, obviously, also for minors. And once they click on they complete the paperwork, they start the assessment. And so it's automatic. And it has been originally piloted only in London and Glasgow, but now we are expanding. And the idea is that if someone is above threshold in some area, they will be directed to the local early intervention team, or if there is a preventive clinic, even to the preventive clinic.
First of all, thank you for your interesting presentation. I'm Dr. Regraghi. Actually, I was wondering, when you said the immigration is a risk factor for psychosis, do you mean all type of immigration, or only the immigration with the chaotic journey? This is the first question. And the second one, I was wondering too about CBD. Do you use it for when your daily practice, or only for studies? And thank you.
Okay, thank you. Very good question. What we know from these meta-analyses, there are basically umbrella reviews. You can have a primary study. You can summarize primary studies in a meta-analysis, but you can even summarize meta-analysis in a kind of meta-analysis of meta-analysis, which is called umbrella review. So it's really providing the strongest evidence for association of a certain risk factor with an outcome, for example, immigration and psychosis. So it's a very strong association. It's being first generation or second generation immigrants and associated with the onset of new cases of psychosis, right? Having said so, it's kind of a spurious association. We do not know why. There may be confounders. That's something which can be only addressed by primary research. But it's per se, it's a kind of proxy of several possibly associated factors which we may explain this link. With respect to CBD, no, it's not possible to use CBD. It's not being approved. So we have this trial ongoing. Having said so, we have done some qualitative work, and our patients are using it, taking it off the counter. And you know, remember that maybe until 10 years ago, we all used blame to our patients with psychosis when maybe some of them were telling us, yeah, I use cannabis and I feel that my psychotic symptoms are improving. And we were blaming them, but actually now we've learned that maybe they were correct, because if they were smoking, for let's say, a joint with high portion of cannabidiol, maybe this could have exerted some antipsychotic effect, right? And that's why we are considering cannabidiol, and we have done 20 years of research in animals and in healthy volunteers, demonstrating that cannabidiol can counteract the effect of THC, which is the other compound which is basically increasing the likelihood of developing psychosis.
Thank you very much for your intervention. My name is Vincent Laprévotte. First of all, I must say that I see a common point between your talk and Ashok Mala's talk, and it's about well, the fact that probably early intervention is one of the most evidence-based intervention actually in psychiatry, and that's very important, and that's why also we should go further now with early intervention in France. My question is about the referrals in OASIS. So what are the most frequent referrals actually, and did you see a difference over time with the new tools that you developed about the referrals?
Yes, very good question. Main source of referrals are GPs, is primary care. So again, we can discuss whether it's a youth mental health headspace-like model. Maybe it's not branded like that, but effectively, most of our referrals, they are coming from primary care, which means that we are still doing a good job with them. So it's working towards that direction. We also have referrals from other sources, secondary mental health, emergency departments. And obviously, yeah, there is a kind of a different presentation and also different likelihood of developing psychosis. So if you recruit, let's say, someone from secondary mental health from the emergency departments, it's more likely they would have accumulated several risk factors. Therefore, they're a bit closer to the onset of psychosis. They present with a bit more severe symptoms, right? If you start using Enter and recruiting from colleges, schools, from the general public and the general community, you will end up with an endophenotype of psychosis risk, which is less severe. They would have accumulated less risk factors. And then you can expect then their likelihood of developing psychosis will be lower. It's a trade-off between intervening as early as possible, but still achieving a feasible approach. And that's where basically we need to balance the two sides of the spectrum.
Merci beaucoup. Une dernière question, s'il vous plaît.
Thanks, Paolo. That was great. You know, one of the things we found over the years, the risk of developing psychosis in the high-risk population, we were using CBT and family intervention. So we had about rates of about 10% converting to psychosis. But the interesting thing was that the people who converted to psychosis, of course, their DUP is very short, but half of them seemed to have something very inherently very serious that they did not respond to antipsychotics. And the numbers were not huge, but we had to use clozapine very early. We published this. I had a fellow at the time who was very interested in this. And just wondering what that might mean is that the most effective interventions might even be before psychosis, that the ones who don't respond are so severe that some of them are inherently treatment resistant.
Yeah, it's very interesting. And actually, we have a publication confirming this finding. So we also found that those who transition, despite our preventive efforts, they may be quite resistant to treatments. I think it's a bit early then to make interpretations because, as you said, even for us, the data are quite small. In terms of transition risk, I know that there is a widespread feeling that transition risk in this field, they are declining, but that's not true. I think that's a bias due to the way these people are recruited into research studies. Usually there is a big push for recruiting for core studies, and what researchers do, we just recruit everyone from the community. And they just teach you, the earlier you recruit, which is good, the more you dilute the risk for developing psychosis. In fact, when I look at local electronic health records and I try to follow up people who were assessed by OASIS and somehow they dropped, they disengaged, actually, and then if we put together, the transition risk is very high. It could be 30, 40%, which means that we need to be a bit more assertive. So if someone is presenting at risk like John and then they're dropping out, their risk of developing psychosis still will remain very, very high. But this risk is not typically captured by research studies.
Merci. On va devoir s'arrêter.